I'm going to introduce our final speakers of the day. It's going to be a joint PT-OT lecture by Emily Cohen. She's a physical therapist here at UCSF. She earned her Doctor of Physical Therapy degree here at UCSF as well, and has been at our BCH Oakland campus since 2019, where she cares for patients in both our acute care units as well as on the acute rehab unit inpatient. And she has a special interest in neurotrauma care. She'll be joined by Julian DeMartini, who's our occupational therapist. He earned his Master's of Occupational Therapy at Keene University in New Jersey, and he joined us at BCH Oakland in 2023. He has a breadth of experience practiced in multiple settings, including early intervention, school-based occupational therapy, and also in the inpatient setting. He was very instrumental at his last practice in the genesis of the interdisciplinary clinic or cognitive rehab team, which focused on rehabilitation for children with acquired brain injuries. So they're going to be talking to us today on assisted technologies for pediatric acute rehab. And welcome. Thank you for closing us out.
Sure, thank you. Hello, everybody. I'm Julian. I'm an occupational therapist here. On behalf of me and Emily, I just wanted to thank you all for staying. I know it's been a very full day. We tried to make this as engaging as we can.
And I'm Emily, physical therapist. We just had a lovely introduction. So just to begin, we have no disclosures, but I do want to point out we're going to be talking about a lot of different technology, and we are no way representing or endorsing any of the technology we talk about. We are really just hoping to share our experiences in using the technology with our kiddos that we have over in our clinic. And we also want to point out we do have a couple patient videos, and they have all signed consent forms.
Okay, so our talk is on the use of technology in pediatric acute rehab. So for anybody who doesn't know what pediatric acute rehab is, we hope these pictures kind of sum it up a little bit. Inpatient rehab offers comprehensive rehab services for kids with conditions that affect their independence and function. These children are typically admitted from the acute service, either from our own hospital or an outside hospital, once their authorization is obtained. On rare occasion, they do directly admit from home. Their services that they get include 3 hours combined of OT and PT a day, and then a whole host of people behind them who help us out too. So of course, speech-language pathologists for patients who have cognitive or swallowing impairments, some of the PM&R doctors and nurses, some of whom we've heard from today, child life specialists, art therapists, music therapists. The list goes on, there's quite a few, and of course, all coordinated by case managers. From our perspective as the therapist, we see these kids for OT and PT each morning and afternoon for 45-minute sessions. From the perspective of using tech with these kids, this really lets us use some of this technology at a high frequency to help them meet their goals.
So we see quite the variety of patients on rehab, but if we had to sum it up into a couple categories, I put them up here. Neurologic patients, we'll see patients with different brain injuries, traumatic or acquired, different spinal cord injuries, or any other neurologic condition you could think of that would require rehab. Patients with different orthopedic conditions, so that might be post-operatively or after a trauma, or patients after an elective surgery, so we'll get kiddos after selective dorsal-rhizotomy surgeries, or after limb lengthening procedures, for example. We also tried to group the technology equipment we'll be talking about into different categories as well. So to start, I'll talk about the tech we use to facilitate gross motor movements in our kids. I'm going to go into more detail about each of these a little bit later, but just to kind of give an overview, the Zero-G by the company AirTech is a bodyweight supported system used for the facilitation of many different kinds of movement, so including, but really not limited to, walking, transitional movements, facilitating crawling and balance. We have the exoskeleton, which is that picture on the top. This is a wearable robot used to assist with standing and walking. And then something on the bottom, which is our force plate. This is called the TIMO. It's part of Tyra Motion equipment. Julian's going to talk about that a little bit later. But this is a force platform that has visual feedback, and it has assessments attached to it so you can determine balance and postural sway. And there's also games associated with it that you can use for interventions in your therapy sessions.
Okay, the second group of tech that we want to bunch together are technologies we use really to facilitate fine motor skills. So you'll see on the top picture here, this is kind of the whole Tyromotion family. One specifically that we use, there's two specifically that we use for fine motor skills. One is called the Amadeo. I have a better picture of this later in the presentation, but it works on digit rehab for robot-assisted grasping. You can kind of adhere individual fingers into it and help a patient work on active, passive, and active assisted range of motion. The Diego is really cool. It's an arm-supported training device. It targets movements in 3D space in multiple planes, and we'll have a video of that coming up. And then the one on the bottom is from a different company. The music glove there is from Flint Rehab. That targets really precise fine motor movements like pinching in the context of a note strumming game. Anyone who remembers the game Guitar Hero is going to be really familiar with that device and its interface. And then the last group here, these are also Tyromotion devices. We called it versatile tech because we can really use these kind of for any kiddo. They're really, really adaptable depending on what the kid's needs are. So Pablo are the sensors on the top, and we have a nice case study coming up that details those. Myro is the one on the bottom that kind of looks like a giant tablet, which can not only measure touch, but pressure, distances. It's really cool and really adaptable. This is just a pretty high picture, general overview of pretty complicated devices. We found that with our tech, though they are really customizable, they work best really once we've had some pretty extensive training on them. Not only to make them personalized for each child and whatever their goals are, but like any piece of technology, things go wrong. And then that's probably the part where you really need the training for. If something seems like it's not going correctly, just knowing how to troubleshoot. We also wanted to mention that the Pablo for the PTs out there can be used specifically as a gait assessment when those little sensors you see at the top are placed on a child's feet.
So getting back to the gross motor equipment, I'll start with the 0G. This is the robotic body-weighted support system. It places the patient in a reduced gravity environment, and it really helps eliminate the risk of falling, which is great. So as the therapist, I can set a fall parameter. For example, if I only want them to go 3 inches below from where they're standing, anytime they try to go below 3 inches, it immediately just stops and they can't go any further. I can also just change that and make it velocity dependent, so you can slowly squat to the floor like that gentleman touching the weight in the pictures. But if you were to lose your balance and quickly fall, it would catch you and not let you go any further. So it really is a safe way to practice balance and mobility. We do a lot of gait training in this device, and it allows the therapist an easier way to facilitate movement without really worrying so much about being hands-on guarding of the patient if they're really at high risk for falls, and allows you to just get in there and facilitate more. We work a lot on standing, statically, and dynamically. With balance, you can do any sort of balance intervention you could think of outside of the 0G, but in the 0G in a safer place. And then it also has its own balance feature where as a therapist, you could set how much you want it to pull the patient and in what direction. So they could be doing something, you'll set it's actually called the trip function. So you literally trip them, pulls the patient to the side, and they have to react. So it's really a way to work on the reactive balance in a safe environment. It's not gonna let them fall. We also at our unit have a crawling harness, so the littler kiddos can work on body weight supported crawling. For all those pediatric PTs out here in the audience, you know how tricky it can be to facilitate crawling in a little kid. We are using all sorts of our body parts to facilitate that, our arms, our legs, we're getting in there and we're trying to handle a lot of different things. So the 0G can really give us more hands, which can be really nice. We could work on things like floor recovery, so getting on and off the floor to standing transitions. You can also work on navigating up and down stairs. So if you have stairs at your clinic, you can go up and down the stairs in the 0G. Unfortunately, our ceiling is not as high as the one in this picture, so we can only do that with some of the shorter kiddos. And I just wanted to point out, kind of off the 0G record, but for the kids who are pretty nervous about going in this, we will pretend like they are a superhero and they are flying. So in the very early stages, if they're super, super nervous and they want to go flying, we'll set the body weight support really, really high, like 90%, and put them in it. They are like moonwalking and flying, and they get super excited, and it's a really good buy-in to then ultimately lower that body weight support down and actually start working on standing and walking and gait training. So I have a patient, actually no, first I have a video of Julian. So this video shows what a fall catch might look like. You can see Julian here gracefully taking a fall, even lifting up his feet off the ground while the device keeps him nice and safe. He could then stand back up when he has his balance and continue on walking.
Can I add one thing here, actually?
Yeah.
So we're going to say later, and this is true, like these devices are really, really safe. But in our first attempt to film this, actually, this is true. When we were doing this fall, it's the first time we've ever seen this error with the 0G, but it came up with like a terminal error and it didn't catch me. So we didn't get that on video. We deleted that one and got the next one. So I was okay. But just a warning that no matter how good the tech is, like we always have to be there guarding and safe. We've probably used this for like hundreds of hours and have never seen that before. So I was happy it was with me and not an actual kid. Just a note about safety.
Yeah. But it will slowly, like even if the fall feature is completely off, it will slowly lower you to the ground. It will never let you quickly fall. So this is the case study. So here we have a patient. So she was an interesting case. She was on rehab twice. The very first time she came to rehab, she presented with a spinal cord injury. Ultimately was C4 Asia D level, was lower upon admission to rehab, but converted to Asia D. She also had the complication of a stroke, which led to a left hemiparesis, as you can kind of see in this video. So on her very first rehab admit, right after her injury, she was ultimately discharged in a power wheelchair. We did not have the 0G device yet in our unit. It didn't exist. And she was only working on transfers at that time. So even if we did have the 0G, I don't know if we would have gotten her in it. A year after her discharge, her therapy frequency in the outpatient world just kind of decreased, and she was only using, I think, the light gate at her clinic. So she wasn't really working on a ton of walking at the time and wasn't working on it at home outside of therapies. So she was readmitted to rehab to specifically work on body-weighted supported gait training and using the 0G. And so this video, I think this was actually the very first day she tried the 0G. She didn't want to use any sort of device or anything like to hold on to an assisted device. She just wanted to feel it out, see what it was like. You could see she's going pretty slowly to start. The body weight support was really high to make her feel comfortable, and the therapist is giving her extra support hands-on to make sure she feels safe, while the therapist is holding the remote control for the device in her hand so she can control it as the patient is moving. After about 4 weeks of practice in this, she was using it and feeling a lot more comfortable. You could see the therapist is even behind her, not even having to be hands-on. The body weight support dropped significantly. It was maybe like 10% at this time. So really just using it for the fall feature. She also agreed to finally use a cane and an AFO, which helped out her gait pattern a little bit more. And then after a few more weeks of practicing it, she felt a lot more comfortable, was able to go outside of the 0G, work on walking outside of it, and in this video you could see even navigating up and down some stairs. We don't have to watch the whole stair video, but she makes it down the rest of them. So going to our other technology device, we have the exoskeleton. So this is a wearable robotic. This part is in quotes because it's directly from their website. It's to help those with paralysis to stand up and walk. And just as a heads up, this was really initially designed for people with spinal cord injuries. This is how it was designed. This is where a lot of the research is shown for people using it with spinal cord injury. It is a robot, so it does have a very robotic gait pattern attached to it, and it allows patients to move within set parameters that we will set as the therapist. So we can set things like the step height, the step length. There's some room for adjustments, but once those are set, the patients are kind of forced to move within those set parameters, which can also make it a little bit more robotic. The one nice thing about it is that there's no track, so like the 0G, you're going back and forth on that one track. The exoskeleton is trackless, so you can kind of go wherever. I will say it's more physical work for the therapist, so you're physically hands-on. There usually has to be one or two more people helping out while using the exoskeleton. But one other nice thing about it, and I'll show this in the next video, is that it allows the patient to have the feeling of walking. And so this patient example, this is patient O. He presented with a C5 incomplete spinal cord injury. He had a lot of tone and spasticity in his lower extremities, and he had some but pretty minimal muscle activation when I was working with him at this time in his lower extremities. he really just wanted the feeling of walking again. So if I had placed him in like the 0G, that would have been a lot of work on us to try to actually facilitate him through any of those movements. Whereas in the exo, it was able to take him through that feeling of walking. In this video, you can kind of see with every step, it is a little bit jumpy and kind of catches. You can see that like robotic pattern with it. You can also see there's 3 people here helping him. So I had to be physically hands-on. Someone's on the remote, someone's helping the assisted device. And then at the end of the video, you can see when you go to turn around, turning in the exo can be a little bit cumbersome. It's kind of a 3-step process. So we'll wait till we get to that point. But like I said, this patient would not have had the same type of feeling of walking without this exoskeleton. So this is the point we get to the turning. So it's really just like a big turn pivot, not supernatural. I don't know about you guys, but I don't always turn like that in real life as I'm going to turn. So yeah.
Okay, so now I'm going to go through a lot of the Tyromotion suite of equipment. I wish we could have patient videos for every single one. We don't. Part of it was just the trickiness of having pediatric patients. Some of it too is that some of the videos we have don't show off the features very well. So a lot of the ones I'm going to show are the videos directly from Tyromotion's YouTube page, and they just do a nice job of like very beautifully cutting and showing some of the different features these things have. So we hope these are helpful to see too. So this is the Myro. This is the one that has a sensor-based surface. You'll be able to see here through the demonstration that not only does it have a touch screen like all of our phones do, but it responds to pressure as well. So all of the games on these are rather simple. Sometimes the kids will ask if they can play like Mario Kart on these, and I tell them I wish. That would be really cool. But you'll kind of see it's games like that where something you do makes something happen on the screen. It's usually like going from point A to point B, kind of like simpler arcade games. At their best. So it also interacts with real objects, so that's like the Myro ball, so it lets us work on some fine motor skills with that as well, instead of just using their arms or their fingers. Yeah, it can measure quite a few things. It measures force, it can detect both push and pull, object displacement, and object rotation, which we can see here with like a lateral pinch. So this one I think is probably the easiest for us as clinicians to learn and set up. This one gets used a lot in our clinic, and the kids really seem to like it. We can adjust the height of it as well, so if we're working with taller patients or patients on standing balance, they can stand and play with it. We can lower it down and do some games in tall kneel, for example. It's very adaptable. Next, we'll go to the Diego. So this is one that has gravity-reduced upper extremity training. You can kind of see from this video that it has these hooks that kind of come down from the sky. It allows you to strap in an upper extremity in 2 different places. Usually we'll go more proximal than more distal. And then it has some intelligent weight relief. So I believe each arm can be unweighted up to about 8.8, about 9 pounds each. And then the control area with this ends up being just all around you. So as you move your arms, that's what makes the game interact on the screen. I'm going to keep this video running while I talk about a case study that we had with a patient who really benefited from this. So this was a 15-year-old female who had OI, osteogenesis imperfecta. She had quite a few orthopedic complications as well, tibial osteotomies, a left humeral fracture. She came to us in rehab, particularly after having a large, I'm going to try to get this right, syringohydromelia, I believe that's how you say that, and invagination of the basilar skull, ultimately resulted in a spinal fusion from her occiput all the way down to T2. So when she came to us in OT, what we found was that she was very impaired proximally in her arms, more so than distally, though her weakness overall was pretty profound. She was unable to really flex her shoulders at all against gravity. She could hang on to a spoon or a writing utensil with a very light grasp, but she was unable to self-feed because she didn't have the elbow and shoulder strength to actually bring her hand over to her mouth. So when we're thinking about function, of course, this was impacting her self-feeding. She was dependent for upper body dressing and lower body dressing. So pretty early on in her care, once I introduced her to this, she really, really loved it. You can see there's even like a VR feature that you can kind of put on and then in the VR world interact with things as well. Initially, she required the unweighting to be at the very maximum, and we could maybe get to about 90 degrees of shoulder flexion, but we kept working at it. Every session, she got a little bit stronger. in the context of these games to promote her activation and endurance. She really loved this. She would ask for this almost every OT session. There were times I had to be like, okay, we actually have to work out some other things. But it was nice to see how motivating it was. Over the time she was with us, by the time of her discharge in November of the same year, she had improved significantly. So she went from dependent upper body and lower body dressing to minimal assistance. She was able to move her arms so much more. Her arm strength, her hand strength had gotten a lot better. She was able to self-feed now independently again. So she attributed a lot of the gains to being able to use this to help her with her arm strength, and I think we all saw how powerful that was for her. Okay, the next one I want to talk about is Pablo. So this is kind of a series of sensors, and you can kind of see in the video here that the little sensor itself is like that little thing that's being pressed right now. That's the motion sensor. And then the sensor can either be directly Velcroed onto any body part, and it can work by itself, or you can put two sensors around a joint, and they can measure the distance between a joint if you want to work on measuring or improving range of motion. They also attach to like the multi-ball there, which works a lot on really good wrist and forearm movements. There's a board that goes for elbow movements. This one's really, really versatile and adaptable. It also allows you to assess range of motion, grip, and gait through the various attachments that it uses. And the case study I had for this one was actually not a kid we saw on rehab, but a kid that I saw, once a week I'm out over in the outpatient hand therapy clinic, and we had a 4-year-old who came in, really sweet little kid, who had a lot of external rotation tendon transfers. And so when he first came in, we treated him similar to the way you might approach an early intervention session, where we're trying to scaffold activities and really get him to use more external rotation just in the context of functional activities. But he would compensate in all the ways you would expect. So a lot of truncal compensations, a lot of shoulder abduction. I introduced him to the Pablo. He was very familiar with video games. He really loved to play games, so I would just call this our video game time during therapy. He kind of bought in right away. And I was able to use a sensor. I used the hand sensor first, which is kind of on the screen, but a little harder to see. I'm going to go to the next slide. It's the one that the man is holding. It almost looks like a Wii remote. We used that one at first to try to work on isolating more external rotation. I think the really great thing about this is you can kind of program it to do whatever you want. So in the settings, as you're setting it up, you do the motion that you want the kids to do, and then it will only react on the screen when that motion is activated. So we started with that, and pretty quickly picked up on that, and then we were able to kind of isolate greater and greater external rotation. In about 4 sessions with this, he gained 15 degrees of active movement, which was pretty good. In the sessions we had before then, he really hadn't gained a lot at all. He would just compensate too much. So we were very grateful that this allowed us to get so specific with his rehabilitation.
So getting back to an equipment that we use for gross motor movements, this is TIMO, again, part of that tire motion equipment. It's for balance training and postural control, and it has, they coined this term posturography. I hadn't heard of that before, but it measures postural sway, and it's really a balance test. So it's a standardized assessment for balance analysis to quantify balance and posture regulation in an upright stance. The TIMO 4 sensors detect weight shifting, determine center of pressure, and body sway and load balancing over your feet. And this data provides indicators for someone's balance, their stability, and their symmetry. It also has a soft overlay foam pad and attachable accessories. You can see in this video, there's like a plastic thing on the bottom that made it more mobile. So that's to increase balance challenges. It has interventions. So aside from the balance test, it has interventions for games. I don't know if you can see in this video, but as you are on there, you're swaying back and forth, putting pressure right and left, for example. You're moving something on the screen and interacting with the game, maybe driving a car, whatever game you set. So there's a lot of different ways you could use it for not only balance, but other things as well. And this lady in the video kind of shows it right now. She's about to sit down, so you can use it for seated weight shifting and control the game in that sense. You can use it for upper extremity functions by putting force through it with your arms, or even like pre-gate stuff. So you can step onto it and off of it, kind of in and out of a staggered stance, and that might be how you control the game. So the possibilities are really at the control of the therapist and their creativity with how they want to use it.
Okay, and then I wanted to quickly mention Amadeo. To be honest, this is probably the one that we have the least experience with. It's really cool, it's just very specific. So in the hand clinic, it's really nice to use. It's this targeted hand and finger therapy. As you can see, every finger gets its own little attachment to Amadeo. All the games across the devices are largely the same. So if a patient learns them on one device, the good news is they kind of know them for the next device. And the way that the Amadeo works is it can, like I said before, be used for either active motion and it can measure it. It can assist with range of motion as well, or it can just provide passive range of motion. It even has an option to be used as like a continual passive motion machine just for the digits. It has a special spasticity treatment option as well, which I think is really useful for our kids who come in with spasticity, like we talked about in the last lecture. And then there's the music glove. So this is the one that is not part of the Tyromotion suite. I want to let this video play a little bit so everyone can see really what this looks like. And again, this is right from their own training on it. But essentially, it's a glove. It comes in a few different sizes. It's made by Flint Rehab. It has these sensors in it that can detect either when your fingers get really close, or if you're working on more precise pinching, you can make it pinch. And then you can see it's kind of music therapy plus occupational therapy at the same time. So it's all about timing. And again, it's very programmable. So depending on how far the patient can pinch or how much they can reach, you can make that trigger what goes on the screen. And as they can progress, we can work on really precise movements. This one has, Music Glove put out they have their own studies. So I guess maybe to some degree we should interpret that with some caution. But they say that it can increase hand function in less than 2 weeks with a total of 6 hours of use. So it's cool that they've done their own research on this as well. Okay, as we get towards the end of our talk, we wanted to talk about maybe a couple of patients that we can use a lot of this equipment with. I think often PT's kind of using the more PT equipment, us and OT are kind of using the more OT equipment. And we have our own goals for the kids, but there are certain kids that we see that really benefit from a collaborative and direct approach. So we're going to talk about Andy. Andy's a 7-year-old child. He has spastic quadriplegia, a GMF CS2, and he underwent a selective dorsal rhizotomy a week or so before he came to us. He was a cooperative, very curious child, and like most of the kids we see, has a natural understanding of touchscreen technology thanks to iPads, and a passing familiarity at least with cameras and sensors thanks to video game consoles like the Switch and the Wii. So we were able to integrate this tech into our sessions for more precise outcomes pretty easily with him. For example, instead of doing a typical prone engagement to work on hip extension and gluteal strengthening, Andy intuitively and rather quickly learned to actively engage his glute and extend his hips as much as he could. He gets into a partial tall kneel or hip extension, and then Pablo can pick up on that, and that would make something happen on the screen. As he gets stronger and he can go up more, we can change the game, advance the level. So maybe like the first level of a game is we're firing a fire hose towards some fires. And if he goes up at all, the hose goes all the way out. As he gets stronger, we can change the level in programming it so that he has to keep going up higher and higher, and the hose slowly makes its way to the other side of the screen. I think what we really like about this is that it takes some of the guesswork and some of the environmental setup out of our hands and just lets us be very precise. So if we're doing games in the gym and we're trying to promote glute extension or any kind of lower back extension, kids always find a way to compensate, right? It's just the natural thing we would all do actually if we needed to get those skills down. But because it's biofeedback and very visually driven, it just helps, especially our kids, learn right away really the specific movements we're trying to target. And so over time, we were able to promote greater mid-range control, different positioning, and really progress his rehab in a way that made sense to him.
And then as he continues to get stronger in his therapies, he might then work on standing. So maybe we'll get on the TMO, start to work on games for his standing balance. So initially he might be very scared and not want to stand up. So we'll put him in the 0G and then also on the TMO. So he's now supported in the 0G. So he feels like he's not going to fall, working on his balance on the TMO while he's playing a game. This makes him more eager to work on standing since he feels safe. Now his subtle weight shifts and riding make a car move on a busy highway. And then when he's ready to take steps, we might decrease the body weight support in the 0G down to 10%.
And then meanwhile, in OT, as he's making really good progress with his PT goals, we can focus more on precise reaching and grasping with the Pablo sensors on his arm for similar activities that he already knows, and then bring in Amadeo to work on composite grip and finger movements as well. So this tech really just allows us to be more precise. It takes a lot of the burden out of our sessions of environmental setup. Instead of having to use things like bed sheets and arm skateboards, we can make it video game based and a little bit more fun for the patients as well. So within 6 weeks, Andy progressed from needing max assist for wheelchair transfer to the end, walking short distances supported out the front door of our hospital with his AFOs, a reverse walker, and a gait belt on his father's hand. The last thing we wanted to talk about were, so what are some of the benefits and limitations of the technology that we use? I'm hoping that some of the therapeutic benefits we've made pretty clear so far. It's really gamified, specific, biofeedback-based tech interactions, and it helps drive our sessions in a way that really these kids are very familiar with because the world they live in is so technological at this point. I feel like sometimes we feel out of date if we don't bring in some stuff like this. The second one, and of course the most important one, is safety. So for example, like we talked about with the 0G, it virtually eliminates the risk of falls during use. We were able to have much better targeted range of motion. We don't have to guess or hope that a certain activity will work the particular movements or ranges that we want. And then we see a lot of improved patient engagement with this. The patients who enjoy these report that they're different, they're fun, and for some, they tell us that they're their favorite part of the session. So their rehab is really augmented by all that these devices allow us to do.
But despite all these promises, we have found some limitations in our current equipment and technology itself. So first, variety. The games themselves are rather simple in their nature. Most are merely going from point A to point B over and over again. Many of our adolescents and patients who are there for longer terms simply find them just too simple and too contrived, and then after several sessions, they get kind of bored of them. And unfortunately, we don't have quick updates to add new games to the system. There's also just the unreliability of tech itself. So the equipment takes time to set up, takes time to clean, put away, not to mention troubleshooting that is required with any sort of tech, which can take up treatment time. Physical equipment can just be easier sometimes, right? So there's the obvious benefit of a ball or a board game is that they never require calibration, they don't go down when the Wi-Fi network is spotty. And then also just this idea of the technology treadmill. So there's a continuous cycle of newer, better tech that's always being released, but it's really hard to keep up with this because of high costs involved and just logistical reasons. So we don't exactly have the most cutting edge. Some of our equipment seems really cool, but it's not the most cutting edge that's out there. Again, our 0G is pretty linear. It just runs back and forth, but there is a newer version out there that can allow someone to go in multi-directions all at the same time. It's kind of in this H track, and so they could go in all directions, which is really cool, and I wish that we had. The exoskeleton was great for a few years, and there's already better versions of it out there. And so we want to highlight that while technology, right, it can never replace therapists, but it really can augment what we do and enhance our therapy sessions when it is appropriate. You all made it to the end of the day. Thank you for listening.